Right, well, thank you very much, Brian. Another terrific session. It's now my pleasant duty to welcome one of our sponsors to speak to us. Ms. Philippa Kirkpatrick is the National Policy Manager for Palliative Care Australia, and she's going to speak to us on this topic. Thank you.
Thank you so much. Thank you for the opportunity to speak to you today. As she said, I'm Philippa Kirkpatrick, the National Policy Manager at Palliative Care Australia, and today I'm here representing the Decision Assist program, which is funded by the Australian Government. I hope you all know that today is the last day of National Palliative Care Week. It's been a busy and exciting week, but a week highlighting the importance of getting palliative care right. It is important because it matters to the patient, it matters to their family and friends, and it matters to their healthcare team. There are around 150,000 deaths in Australia each year, and 90% of these are from people dying from a chronic disease. Providing care to people at the end of their lives is something you probably all do every day. And while some of this care might be in a hospital, much of it is provided in the community and supported by GPs. Decision Assist has been designed to support physicians, nurses and aged care staff to provide high quality palliative care and end-of-life care to their patients. It also provides support to facilitate discussions about goals of care and end-of-life care preferences, as well as documentation of advanced care plans. I'm just going to give a very brief overview of three of the services offered under the Decision Assist program. Firstly, we have GP education programs, and these are free and accredited by the RACGP and the Australian College of Rural and Remote Medicine. The programs are based on 3 prognostic trajectories and aim to provide practical support for GPs to deliver care as their patients transition from curative to palliative care. Second, we host a national phone advisory service. This service provides 24/7 advice from a palliative care specialist to support decision-making about the care of patients in the palliative phase. You may seek advice about symptom management or medication management, or you could just use the service to talk about your planned approach for caring for your patient with someone else, someone whose core business is providing care to people at the end of their lives. This can provide assurance and build confidence that your planned approach is the right approach for your patient. And just finally, we've launched 2 apps. There's the Palliaged GP app and the Palliaged Nurse app. And these apps cover advanced care planning, case conferencing, and care planning for the dying person. And these are available on the App Store or from Google Play. So I really encourage you to tell your colleagues about the Decision Assist program and encourage utilisation of the resources that we have on offer. You can find more information, including the phone number of our advisory service, on the Decision Assist website, which is decisionassist.org.au. Thank you so much.
Thank you very much, Philippa. Now, we've got to do a quick stage reset for the next session on the medical profession's role in closing the gap, which the President will chair. So please don't leave. This is going to be remarkable. We're going to see this happen in about a minute and a half.
The All right, well, that was a very efficient changeover of set. Now, I must admit I'm a little bit intimidated by doing this session because I hardly hold myself out as an expert, but I am joined by Brooke Boney, who's a political reporter for SBS World News in Parliament House. She's an Aboriginal woman from the Gamalori and Gamaroi country in northern New South Wales. She's passionate about the role media plays in shaping the way Australians think about Indigenous issues and culture. So she does have a very important job, and she's spent time travelling to remote Indigenous communities both in Australia and abroad. So the idea of this session is that we are going to talk about some of the issues that not only face Indigenous people, and I know that there are many experts on this subject in this room, so I would invite those people that do have expertise to share with us, not only to ask questions but to throw in their thoughts and comments about some of the issues and hopefully solutions that they have on this topic. I mean, as I said in my speech yesterday, it's one of the greatest things that the AMA President has, both in terms of the honour of doing, but also I think in terms of a responsibility and advocating for improvements in outcome for Indigenous health, and the whole range of things that we do, not only focusing on the individual diseases but trying to shape public opinion, working with Indigenous people, particularly through things like Close the Gap Steering Committee that we're a part of, the Recognise campaign that the AMA was one of the founding signatories of, and all of these things I think make a contribution. I'm sure, I'm told, are very much appreciated by the Indigenous community and their leaders. We also, much of our advocacy around Medicare and funding, the funding for health programs, flexible funds, all of those sorts of things, they go directly to the heart of Indigenous health as well, and I think we have a very important role to play there. So I'll hand over to Brooke, who's going to do a little introduction. You can do it from the chair if you'd like, or...
I think I'll stand.
Okay.
Thank you.
Thanks.
Thanks, Brian.
Please welcome Brooke.
Thank you all so much for having me here today. I'd just like to start by paying my respects to the traditional owners of the land that we're meeting on today. So I'm standing here in front of you, and I look like you and I sound like you. I'm what some people might consider an easy to digest Indigenous person. It's not a difficult thing for you to come across me. My skin is a little bit more tanned, but it probably just looks like I've been on holiday somewhere warm. So what is it that we know about Aboriginal and Torres Strait Islander people? We know a lot of statistics. Our life expectancy is 10 years less than yours. We're poorer. We're less likely to get jobs, and we're less likely to keep them. We're more likely to get cancer. We're more likely to get diabetes. And we hear so many of these statistics, you guys especially, that we almost become a bit numb to them because, some of them are so staggering and we hear them so often. So let's just take a little minute here and have a think about what those statistics really mean, what they really mean to someone like me. In real life, in my life, every day. So last year my grandfather had his 70th birthday, and he's the first person in his lineage to turn 70. All of his younger brothers have died already. It means that my mother is more likely to be beaten by her partner than your mother. It means that my little sisters are more likely to be raped. It means that my little brothers, we're better at putting them in jail than we are at making sure that they finish high school. And we're, as I said, more likely to get diabetes and suffer from a whole range of chronic illnesses. And like I said, I'm one of the ones that's had an easy life. I'm one of the ones that looks like you and sounds like you. So imagine how difficult it is for the people who don't look like you and who don't sound like you, whose lives have been a lot harder than mine. Just imagine, just for a minute, these traumas and these experiences that every Indigenous person, nearly every Indigenous person, carries around with them. We carry them around with us everywhere we go, to school, to work, and when we go to visit the doctor. So imagine these traumas and all of these hurts and all of these awful, awful things that happen to us in our lives. And I want you to think back to the last time you had an interaction with an Indigenous person. And thinking about all of these things, would you treat them any differently to what you did? Because we do hear a lot about equity and a lot about equality, and you hear people say things like, well, I treat everybody the same, I'm very fair, I treat everybody equally. But we're not the same, and we can't be treated equally. All of the evidence and all of the statistics show us that. We're probably never going to get more money, try as we might, for Indigenous health or Indigenous affairs more broadly. So to do more in the Indigenous health space to create better outcomes for us, we're going to have to do things, people like me and people like you, in a different way. Because we're trying to do something that's never been done before. So we're going to have to do things like be more creative and, as Malcolm Turnbull likes to say, be more innovative. We're going to have to push the boundaries because we're going to have to do things that we've never done before to achieve those outcomes. That's it. Thank you. So, Brian, the AMA has done a lot in the last few years in making sure that Indigenous affairs are kind of pushed to the front. Can you tell me about, or tell everybody about, some of the things that you guys have been doing?
Well, I think the first thing is you've got to have credibility. I think I'm very conscious of the fact that as a well-intentioned white person, as is often described, there's no point turning up, visiting a community and then not following through on something that you say you're going to do. I think I've been very lucky in that I'm not trying to build something from scratch. I think the fact that the AMA has, and successive presidents have made Indigenous health a priority, meant that when the AMA does turn up, it is actually with credit and value. So, the fact that we are part of a number of partnerships with various Indigenous programs, that we were in there with the Recognise campaign, that we've always been there with the Close the Gap steering committee, and contributing to ideas and focusing on Indigenous health means that we're not new to the space. But I think every AMA president kind of has to establish a little bit of credibility, and that involves getting out, actually meeting the Indigenous leaders, speaking to them, listening to them, and one of the first things that we did was go up to the Northern Territory. We went to Alice Springs. It's where I met John, and I got my 3-hour lecture on John about Indigenous issues, and then went up to the Tiwi Islands with Rob Parker, and it's that sort of experience. You can then come back and actually start to talk about things, at least with some level of knowledge and education. And in fact, I'd done a little bit of work in the past as well, but So I think, having that relationship is really important, and I'm confident that whatever happens in the future, that the AMA will continue to have that focus.
So we'll go to some of the questions that we've got here, but please feel free to tweet the questions in or to jump up to one of the microphones as well. One of the things that I always get asked about is why hasn't the goodwill of so many generations of political leaders translated into better outcomes for Indigenous people, particularly when it comes to health outcomes?
I think that's a great question. I think, first of all, the problems are very severe. There are improvements that have been made. There's no doubt about that. And, I point to some of the early intervention work that is happening, the fact that immunisation rates are high, birth weights have improved in many areas. Those programs are having an effect. And as our Indigenous report card, I think it was 2014, really focused on early intervention. So I think, we have to celebrate the successes that we are actually having, because there are some. That's the first thing. The second thing is I'm starting to get a little bit annoyed with the idea that the gap in life expectancy is an average of 10 years, because it's an average. And I think we've got to remember that there are people that are obviously improved and are doing well, but there are many people for whom the gap in life expectancy is much greater and can be up to 26 years. So we've got to remember that we're dealing with a very different range of problems. So the problems in particularly delivering services to Indigenous people in remote communities is very difficult. I think it's easy for people to tire of the message, as you outlined, and one of the first meetings I had, I've got to say, with Peter Dutton was, we covered a few things in that meeting, but getting to the end, so I can probably say this now, but there was just an overwhelming sense that we're giving all this money to people for Indigenous health and it's all being wasted, we're not seeing any benefits, so we're going to pull the money and do something else with it. And I just thought, that is not what you need to be doing. There are successes, take an interest. The last thing we need is to be taking our foot off the pedal. Sure, there can be improvements that can be had in terms of how you spend the money and the effectiveness of that spend, but you have to keep funding this issue. And we've said many times that solving a crisis that affects 3% of our populations as one of the so-called lucky countries and wealthiest countries, it doesn't make any sense. But the other aspect is, and the thing that probably I've learned the most, just thinking about these problems, and it really came home to me when I got asked to go to the British Medical Association in London, of all places, delivering an address on social determinants. I mean, you can think of housing, you can think of clean water, you can think of all of the traditional social determinants, but the thing that really struck home to me was our history. We haven't yet dealt with the history of colonisation or whatever you want to call it of Australia by non-Indigenous people. The tight connection, understanding the tight connections that Indigenous people have with their land, the fact that the dispossession of the land and the effects that has had. The stolen generation, I think, is also a huge issue in the concept of health for which Indigenous people, it's not just a disease or physical state, it's a sense of social and emotional well-being. We have to start to try and do a better job of understanding what some of those historical, cultural, psychological barriers that are to actually improving health outcomes. And that's why I think things like constitutional recognition, whether it's treaty or recognition or whatever it ends up being, these are important steps to actually improving not only the outcomes in health but in other things as well. And when I delivered that talk, I thought, this is going to go down like a ton of lead here in London. But I was very pleased because the Canadian president got up and she said, "Oh, you've just stolen my thunder," and she gave exactly the same talk about the Inuit in Canada and the issues, including stolen generations that had happened in Canada. And it was a real education to see that this was not just something that had played out in Indigenous Australia, but it actually played out in other places as well.
Go to a question.
Thanks, Brooke. Brad Frankham from New South Wales. I thought your words were very powerful. Thank you.
Thank you.
I'd just like to highlight the fact that we have a large population of Indigenous people who live in urban environments, and their health outcomes are also poor. And as an AMA, we need to not think that it's only remote people who need our help. And the second thing is, I think the universities are doing well with now facilitating the graduation of Indigenous medical students, and there are some fantastic people doing medicine and who have graduated, but it's a responsibility for all of us to be expert at delivering Indigenous healthcare, not just a small number of Indigenous graduates. And Western Sydney University, who I used to work for, have placed every final year medical student in an Aboriginal medical service for 5 weeks in their final year of medicine. And I challenge the other universities to match that and do better. I know some do and some don't. But I do think we can't expect just a small number of people to take on the whole burden of delivering Indigenous healthcare. It's a responsibility for all of us. So it's more of a comment, but I'd be very interested in your views on that.
Absolutely. I think that's what I was trying to get to when I was saying that Indigenous people, although we all don't look like the sorts of people that we think of traditionally, people from remote communities or people with very dark skin or different facial features, but we're still carrying around the same traumas and the same, same rates of chronic disease as, not as bad or as poor, I should say. But they're the things that we should think of when we're interacting with people who are Indigenous. That just because they look like me or sound like me, that they're not also, carrying around these burdens as well. And that's something that we should think about when we're treating someone in Blacktown or Redfern or, in Kingston.
So just to follow up on that, I absolutely agree with that. The largest, population of Indigenous people is in Western Sydney. And I think when we think about Indigenous health, and this topic is about, what we can all do, it's not something that's in the Northern Territory or Queensland or WA outback. It affects the whole country. And so we have Indigenous people, and sometimes it's easy to identify, sometimes it's not, but we actually have to think about all the things that we can do in an urban environment. And there is an issue about capacity building. I mean, the Indigenous scholarship that the AMA runs is one thing, but we have to get better at, first of all, recruiting Indigenous people into medical school, which we're doing, but also supporting things like Indigenous healthcare workers, which actually provide significant workforce in Indigenous communities, and actually provide an economic benefit for those communities as well. And I think there's more work that we can do to support those programs. The Aboriginal medical services, the one in Western Sydney has just fallen over, and so there's a problem there with the infrastructure and how we actually deliver those services. So we've got to make sure that we do a better job in actually supporting Aboriginal medical services, which are vitally important in delivering these services as well.
We'll go to a question over here.
Oh, thank you. I'm Paul Bowd. I'm a paediatrician from Darwin. I agree with the comment about most Indigenous people are living in metropolitan areas, but across the top of Australia there are 100,000 Aboriginal and Torres Strait Islander people from the Kimberley, Northern Territory and Cape York. And arguably their health statistics are worse, and I'm not just trying to up the ante by saying ours are worse than yours, but if you look at the figures, the state of health, particularly child health, is much worse in this 100,000 people. And the problem is that unless we get serious about addressing this in early childhood, that the cycle will continue. Most of the chronic diseases have their onset in childhood illnesses and adverse early childhood events. So whilst I agree with the comments that there's a lot to be done everywhere for those 100,000 people, there's more needs doing. Thank you.
No, I absolutely agree. I mean, it's well borne out that the level of remoteness, and particularly for people in the top end of Australia, you know, it's very clear that their health outcomes are worse. And that's what I was saying before. We can talk about averages in terms of life expectancy or other gaps, but, you know, in many communities, the gaps are very much worse. And so until we start to address those really extremes, we're never going to actually improve the overall gap in Indigenous health.
Absolutely. We've got a question here. To save me from despair, can you enumerate some of the improvements that have been achieved?
Yep. No, and that's the thing. You go to, you know, one of the things you realise is you travel around and you fly 500 kilometres out of Alice Springs to this dirt strip, and you go to this little town and their healthcare service, and then there's, you know, a couple of doctors that have flown up from Melbourne and are living there for 3 months, and you think, oh, you know, these guys are the real heroes. These guys are doing, you know, living in these communities, and the nurses, I've got to say as well, and are actually delivering the services and doing the work. They get no recognition for the work that they do, but they are passionate about Indigenous health and healthcare, and, you know, literally spending 3 months at a time, sometimes more, sometimes less, sometimes living there, you know, full time. But, you know, it's a real commitment, and I'd be interested to know how many doctors are actually doing that, but it's an awful lot, particularly of GPs. And, you know, we don't celebrate that and recognise that commitment of our colleagues enough in my book.
I think that goes to what it is that you can do as an individual as well, though, doesn't it?
It does, but it's not possible for most people to, you know, with families and other commitments, to spend that amount of time. I mean, it's a real vocation to go and do that work. And there are many people that do fly-in and fly-out services. I think those are very valuable as well. But, you know, even in your own practice, just being aware of things like the Close the Gap, PBS benefits that can be had by just recognising someone's eligibility and writing Close the Gap on the script. Some of the specialist funding that can be utilised so that people, you know, don't bear any cost. You know, many people that are working in metropolitan areas are just completely oblivious to these programs even existing. So I guess, you know, one of the things that came through in our task force at the last meeting was actually the need to actually highlight some of those issues and educate people a little bit more about some of the simple things that they can do for people as well.
Thank you, Jo Flynn. Just a wider comment. I think Brian's, I'd like to commend the AMA for their leadership on this, and Brian in particular, and I think the references to the historical issues in Australia that haven't been acknowledged are important. I think the other thing that's important to acknowledge is that Australians are inherently quite racist, not necessarily consciously racist, but unconsciously, and I think that racism is particularly clear in relation to Aboriginal and Torres Strait Islander people. And I think, you know, it informs the background of our culture, and you can go back to Adam Goodes, we can go back to lots of things, but there are plenty of examples of it. So people in this room, doctors in society at large, we are leaders of society, and I think we need to recognise that tendency in ourselves, in our colleagues and in society. And just as, in a sense, the College of Surgeons, we're going on to a discussion about the culture of medicine and bullying. I don't think medicine's worse. In fact, we hope it might be better than the rest of the society in this regard, but sometimes we have to face our own problems, inadequacies and failures in order to address this. And so I know that sometimes when medical students are exposed to curricula about Aboriginal and Torres Strait Islander health, they sort of groan and say, but, you know, I'm not going to work there, it's not to do with me. But actually, over time, when they discuss the same issues and the way medical education has changed, they recognise the importance. And I think that's happening now through the colleges. There's a whole project in accreditation. But I think it's really important for bodies like the AMA to take leadership here. So thank you.
I think it's really hard to be conscious of your own your unconscious bias when it comes to how you deal with people or how you treat people. But I think the first step in moving away from that sort of behaviour is just questioning it. I mean, are you treating someone fairly because you treat everybody fairly, or are you putting in extra effort, or are you making judgments about that person before you've met them, or before you've interacted with them? Those are sorts of things that happen, across all sectors. But it's particularly important when someone comes in to receive treatment for something that we make sure. The situation with Gurumul is a perfect example of that. The other point that you made was
the issue of racism.
Yes.
I'm glad you brought that up, actually, because there is an issue with racism, and it is something that we need to tackle. I think that Adam Goods episode, or period where he was being booed, and I mean, people have tried to justify it through all sorts of means, but there was an element of racism to it, and to say otherwise, I think would be silly. I happened to be at the Garma Festival up in East Arnhem around that time, and the sense of disappointment amongst the people that were there was quite palpable. And Noel Pearson actually gave a very passionate speech about how he felt about that whole period, and what he thought he knew about his fellow Australians, or what he thought he knew. And he said words to the effects that, "I think I know them too well." And it was a very inspirational speech, but there's no doubt that there is an element of racism in our country, and we have to deal with that. I think we've come a long way, but until we actually get a better understanding between non-Indigenous and Indigenous Australia, we're always going to struggle with this problem. And it comes also to how we deal with people in a hospital or medical setting, as you were saying before, because the concepts and the way that we deliver care is, in many cases, inherently racist, because we don't deal with or recognise the culture that we should have a better understanding of, to allow better engagement with Indigenous people, to allow them to achieve better health outcomes. And it's not just putting pictures on the wall or Indigenous art, it's actually understanding things like avoidance behaviour. The fact that you can't put two patients that may have an avoidance issue where they actually are not supposed to engage with each other in any way, because one will leave and go out of the hospital. So understanding all of these things, and they do all this stuff very well in places like Alice Springs, but there are many other places where that understanding of culture amongst non-Indigenous people needs to be improved if we are going to overcome this element of racism that is inherent in our healthcare system.
If I could just speak to the racism element as well. When there are, massive events like the event with Adam Goods and the booing, these sorts of things, that it's not just unpleasant for Indigenous people, it makes us sick. It is so stressful that you don't feel like you ought to get out of bed in the morning, because you know that when you go out there, you're going to be faced with questions, a barrage of questions about, oh, do you think it was racist? Why do you think booing is racist? And every Indigenous person gets asked those things. We all carry it. We all carry the burden of that when that happens. And it's not just something that we can just shrug off or not think about, because it goes to our core. We then have to explain that we've been putting up with things like this for decades. It's not just an incident on a footy field to us. This is stressful and traumatic and awful and scarring for a lot of Indigenous people. So when these sorts of things happen, we can't underestimate the power of symbolism. And I think that goes to reconciliation and the work that the AMA did with Recognise. We can't underestimate the power of that sort of symbolism, because for me to wake up in the morning and know that I'm going to have to answer all of these questions on Adam Goods being booed, or alternatively to wake up and know that, 9 out of 10 people that I walk past on the street have voted yes to recognise us in the Constitution. It's a big difference. And that one means that you do want to get out of bed and go and interact with your fellow Australians, and the other means that you'd rather just hang around with other blackfellas and not associate. We've actually got a question on here. Following on, this is from Janice Fletcher. Thank you for your question. Following on from Paul's plea, how can we as a nation commit to improving childhood nutrition for Indigenous Australians as the first step to improving outcomes?
Well, I think some of the programs that actually John Boffa mentioned yesterday, or yesterday evening, important. The Abacarian programs, the OLDS program that actually do that early intervention, having the nurse come in and understanding the importance of breastfeeding and nutrition and those sorts of things are clearly important. But nutrition obviously has to follow through from there, and we actually had a meeting with Coca-Cola recently, in fact last week, about what we can do to work with them about some of the fact that there are so many, Coke sales, particularly in remote communities. I mean, I think there's a photo of one of my friends walking around with a Diet Coke, but actually in many places it's full-strength Coke. And obviously that's a bad combination when you've got a high rate of diabetes. It is also very difficult to get nutritious food into many of the remote communities. When we spoke to the storekeeper in Kintore, the nutritious food would sell out very quickly. So the vegetables would go very quickly. Even though it was 500 kilometres away from Alice Springs, they would try and get stuff there. They had programs in their stores to try and lock the chocolate up until after 2 o'clock in the afternoon, which had caused some angst apparently, but they're trying to gradually change things. But you have to take a step back and say, how many people actually have the knowledge and skills to prepare a meal and cook a meal in the way that we do? Because when you start to talk to people that, living in these remote communities where there's 16 people living in a house, which is not an uncommon scenario, where there's really a very poorly functioning kitchen, where they often don't have pots and, so this microphone's going in and out, pots and pans to begin with. Actually preparing a meal is very difficult. So, it goes back to a very basic level of the social determinants of health.
I remember being on a trip once with the Fred Hollows Foundation, and we went to a little community called Manyalaluk. And we went to the shop, just the local store, to get lunch. And I just wanted a sandwich. And so I went in, there was a sandwich, it was frozen. I think it cost me about $8 or $9. It was a ridiculous amount. It was just, a ham and cheese sandwich. I had to wait for it to thaw out in the sun. While I was in there, a woman who was about my age came in. She had, 3 littlies kind of hanging off her, and they were getting their lunch as well. And for the same price that I paid for my frozen sandwich, she got some hot chips and a loaf of white bread. And that would have fed 4 people instead of just 1. So nutrition it's so difficult in communities where, like you were saying, access to fresh fruit and vegetables is...
Yeah, so it's the ease of access and the cost. And so one of the things trying to do started, and I know Simon Tatz is keen to follow on with this, is to actually link up, people like Coke, and they, might paint them as the evil seller of sugar or whatever you want to do, but the fact of the matter is it's a very popular product, and if they don't sell it in the store, they'll just drive into town and bring it back. But they are trying to do things in their store. The missing link is they don't actually have links with people outside the store, the health services and the people that actually can advise and do the education and link between and change people's behaviour. That's the role that the AMA, I think, can play in trying to improve some of these links.
We'll go to a question here.
Yes, thank you, Brooke. I grew up in the southwest and Western Australia at a small country school. Some of the students were Indigenous students. They went back to the 3 Mile Reserve. There was no running water, there was no electricity, and alcohol was a problem in some of the families. Their chance of achieving anything significant educationally was almost zero from the beginning. I've also had time as a young doctor. I was a medical student first, working in the Kimberleys, and then as a doctor for 12 months in the Pilbara. Flew out to Jigalong once a fortnight as part of my regular run. So I've had a reasonable amount of exposure to the problems of Aboriginal people in those sort of communities. My question really is that it seems to me that the health is at the end of the line. The bad outcomes in health are often the end of the line for, in many cases. Aboriginal children, of course, if they can't hear, they can't learn. If they can't learn, they can't properly achieve anything very much. They won't get a job and they'll end up in jail. That's the trajectory that we're dealing with. What suggestions do you have in terms of improving the educational opportunities? I mean, it's a massive issue, and the Commonwealth Government and state governments have tried very hard, but what would be your recommendation about what can really be done to make sure that Indigenous people in this country have the same educational opportunities, the same real chances in life that the rest of us have had?
I think the thing that's difficult about what you're saying is that there are so many elements that come in to influence the end outcome. And so if you are a mum and you're being abused by your partner, you don't have the energy to then cook for your child, who's then going to go to school with a hungry tum. Or if the child is so traumatised because of what they're seeing in their community, they're going to go to school and they're going to sit there and, despite their hearing problems or, what's going on with their middle ear, they're not going to be sitting there thinking about algebra. They're going to be sitting there worried about their mum or their auntie or their grandmother. And so it's important that we think about all of the issues at the same time, which I guess is why there are, the Close the Gap targets go across a whole range of things and not just, health and why things like incarceration targets are important. Because those early years, like we know, if we're not focused on making sure that these kids go to school and are actually able to learn, they've got a full tummy and a full heart, then it's almost impossible for them then to achieve once they are 16 or 17 and leaving school and getting apprenticeships or deciding whether to go to university or not. So I think that the important thing is that we think about it holistically and not just each problem in isolation, because there are so many things that feed into it.
The other unsung heroes, I've got to say, are the teachers, particularly in the remote communities. I mean, you go out and alongside the nurse's little house is the teacher's house. So they're out there in these communities teaching primary school, and they do a fantastic job. And they have all sorts of innovative ways to get children into school. They can't go to school or they can't swim in the pool unless they actually, attend school. So all of those things can be very motivating for kids to actually attend school, and it also helps to keep people clean because you can, they swim in the pool and all of those sorts of things. So I think, there's clearly things there as well. The other aspect, sorry, can you hear me? Yeah. The other aspect, though, is I think the Indigenous advancement strategy of the government is not quite right, because health has to be a foundation, as you said, for many of the other things. You can't learn at school if you can't hear. People's eyesight's affected. You can't hold down a job or do training unless you're healthy. So we've got to start to get back to health being a foundation, whereas the government's Indigenous advancement strategy really focuses on education, employment and training and, safe communities. But the aspect that's missing is health. And I think people, the government again has seen health as not the priority that it really should be. And that's, I think, our argument is to put health back up on a pedestal with all of those other things and maybe even the foundation for them.
We'll go to a question over here.
Hi.
I've been waiting very patiently.
I'm an obstetrician, so Brooke, thank you very, very much for your talk. It was just fantastic to hear. I'm on the board of Western Sydney Local Health District, and Brian alluded to the fact that the local Aboriginal Medical Service, which had been running and providing a service for the local community there for a long time, basically went into liquidation. And I guess I just want to raise something which I find quite a disturbing thing, and I just want to see what your response is. That as I talk through this, and other times when I've talked about other issues unrelated to this, in terms of community-controlled Aboriginal health organisations or other community-controlled organisation, I get the impression from a lot of people who should be working with those communities that they feel that the intention to allow the community to be in control of the service compromises the normal governance processes and the standards that would keep the organisation running on an even keel and prevent these failures. What's the way to sort of get around this? What's the way to make sure that this doesn't interfere with our desire to continue to support these services and allow them to be controlled by the communities?
My understanding of the closure of that service was that they didn't meet all of the outcomes for the Indigenous advancement strategy, I think, and then also there were governance issues as well. So they had their funding reduced, but then also there were governance issues. I'm not sure, obviously I'm not an expert in running a practice or anything like that, but couldn't there be a scenario where there's mentoring or partnering with Indigenous and non-Indigenous organisations where that sort of knowledge or expertise could be shared? Or, obviously there needs to be rigorous governance of these organisations because there is so much money in Indigenous affairs, and obviously where there's money there could be people who want to try to take advantage of that. But couldn't there be some sort of partnering or mentoring program that would fix those sort of issues or share that sort of expertise?
Well, I think you're right. It's about building capacity for governance. I mean, people talk about self-determination, and all of the Aboriginal medical services or Aboriginal community-controlled health services essentially have boards of Indigenous people in the community. They have boards for other community services as well. And there is a process, I think, that's happening of educating people around what governance actually involves and how accountability and transparency and responsibility. But that takes time. And people are doing the company directors course and those sorts of things. I think there's clearly a role for probably the Institute of Company Directors to do a lot in this space, but I think there are going to be mistakes. Things are going to fail from time to time. Our challenge is to try, I think, to get the balance right between allowing self-determination and encouraging self-determination and but still making sure that we don't have huge financial failures and services that fall over. We've got to have some balance there while this, I guess, skill and capacity is allowed to grow and build.
So we've got time for a couple more questions. I'll just take one on here. This is from Kath Browning-Carmo. In any developing country, we know that empowering women is key. What's being done to galvanise Indigenous women to improve health outcomes?
Right. Well, it is the women that holds many of the communities together. You're probably more qualified to speak about this than me. But one of the tragedies is that a lot of the elders, I think, this is what's related to me. The elders in many of the communities sometimes, obviously, are missing because they die prematurely, or they're in town camps because they have to be in town to receive medical care. And it is the women of the communities that actually keeps things together. So I'm not sure how to answer the question really, but I think people need to recognise the importance of the elders, male and female, in these communities and what an important role they play. I mean, one of the important things about getting the dialysis chairs back out into all of these remote communities in Kintor and Utopia and other places is, you know, there are these dialysis units, amazing, you know, one or two chairs, but it gets that person back out into the community because they often are the most, you know, many of the senior people in the community, which are important for the social fabric of the community, rather than having them off in town where they're isolated and their community feels their lack of presence as well.
I know that in my family especially, it's kind of my nan is the matriarch of the family and just kind of pulls us all into line when we need to be pulled into line. We're all a little bit terrified of her. And I know that that's the same in other Indigenous families and in other communities as well. It is so often the women that lead the charge when reform needs to happen in communities, and, you know, to kind of pull everyone into line. Even this week I was watching a story about Arakoon and the situation that's happening there with this local school. And it's all of the women standing up and, you know, rousing on everyone, getting up everyone, saying, you know, you need to do this, you need to do that. And I think that women just naturally in these communities have taken on a really important matriarchal leadership role. But I think it's also really important that we don't disempower men in the process of this, of closing the gap. We've seen some really, really horrible scenarios in the Northern Territory since the intervention there, where men feel really disenfranchised and, you know, feel really disempowered, and that has really negative outcomes and impacts on the community as well. So yeah, it is women leading the charge, and that is really important. But it's men also really play an important part in bringing communities together and making them safe and good again as well. So we'll go to you here.
Hi, my name's Kate. I'm an intern in Melbourne, and I spent some time working as a physio in Darwin, and I feel like I just scratched the surface of some of the issues and solutions. I'm part of the Doctors in Training group at the moment, and there's a portfolio for Indigenous health, public health and community projects. I was just wondering, are there any tangible things that we can do as a group, this unique constituency, to help close the gap, whether that's in a symbolic way, strategic, building alliances?
Yeah, well, I think there are many things that we can do, and the AMA certainly has a role, as I've outlined, but I think just about every university and research body has some links to try and help promote Indigenous health as well. So I think it's firstly a matter of people following through on their interests. When you go to a place like Alice Springs, what you find is that there are all these little, there's Baker IDI, the Poach Centre, Centre for Rural and Remote Health, and all of these other universities that have sort of got these places there. So there are plenty of opportunities for people to engage through those groups. One of the things I think as doctors as an organisation is, again, trying to lead some of these debates around I guess the biggest social questions that we face in this country about how we view Indigenous health as an important issue, and all of the things that I've talked about. It's not just the diseases, but it's all of the, addressing all of the historical and cultural issues as well. So I think, as a professional association, but even as individual professionals, I think, that is kind of a key role that all of us can play in trying to close the gap.
I'll just pick on one little point that you made, that you feel like you're kind of just scratching the surface and there is so much to do. I often feel like that as well. Sometimes you get kind of almost overwhelmed by just the job ahead of us. But Uncle Pat Dodson said to me once that there are just so many people who think the same way as you and feel the same way as you and who are working just as hard in trying to make it better. So don't ever feel like, you have this mountain to climb on your own, because we're all in it together. We're all kind of pushing in the same direction. And things are getting better, very slowly but surely getting better. I think this might be the last question.
Rob Parker from the Northern Territory, psychiatrist. Look, I just, thanks, Brooke, for a great session. Really interesting. Just getting back to what I think Brian and yourself have been talking about doctors not being involved just in the health issue, but also the broader social context. I just had memories of my wife's community back in the 70s when there were Aboriginal people working in Aboriginal jobs. So you had Aboriginal people building houses, Aboriginal plumbers, Aboriginal mechanics actually working in communities, because at that stage the mission had actually put an effort into making sure people went through apprenticeships. And so people who were actually at school could see there was some reason to be at school because there was some outlet to it. And then it all fell away in the 80s and 90s when they got teams of contractors to come in and no one bothered with that continuing training. So I think there is and again, I'm sort of wondering about the efforts of Clontarf, what they're doing in the education space. And again, alcohol policy. I think alcohol policy is a key issue that I'm trying to continually deal with in the Territory as AMA President, because I think it has probably one of the major impacts on why kids aren't going to school, as you mentioned, why people are ending up in prison, both men and women, much higher rates of imprisonment. So I think it's just getting back to sort of like a summary of what you guys have been talking about the, not just, health is a much broader context than just how someone's ears are. And so the medical profession being aware of that and the effect of racism. I mean, every time I go to a meeting now, I talk about the NIRA, National Indigenous Reform Agreement, and how important that concept was, even though the money's just about to run out. About terms, getting back to what Paul was talking about the kids' early years and money being available for that. And I think one of the big problems in Australia is a lack of concept about the broad picture. And people are doing something else, but the actual strategy is lacking, and I think that's why the NIRA was so important. And I'm just hoping we might get back to that, and I hope to continue acting in that space. But thanks for your session, it was good.
Thank you. Well, we might take that as a kind of opportunity to wrap up, if you would like to go first.
Well, thank you for all those comments. I was waiting for Rob to get up and contribute, giving his expertise in this area. Look, it's clearly a really complex, difficult problem to solve, and it's going to take a generation, if not generations, to actually solve it. But it will be impossible to solve if people fatigue or if they shy away from the issues. And so I think the job for the AMA, but all of us as individuals, is to keep advocating passionately about this issue, about calling out the problems that exist, about calling out the problems with policy, as well as contributing as individuals and organisations on the ground. So, I mean, as I said, I've got a very easy role, but I was constantly, I guess, humbled by the efforts that I know people in this room put in to Indigenous health, but the many other of our colleagues and nurses and physios, everyone else that is out there actually in the communities and actually doing the work, because I don't think those people actually get enough credit for the sacrifices and that they make and the dedication that they have for their fellow men.
Well, thank you all so much for listening to us speak for the last hour. This is really, really important to me because like reporting on politics or, doing any sort of news story, this isn't just about, a whole bunch of statistics or a whole bunch of words. For me, this is my life. This changes the way that my little sisters live, my little brothers live, the way that my mother lives. And there is such a huge task, a mammoth task ahead of us, but we're the only ones who can do anything about this. And so if there's anything that you can take away from this is just please don't stop trying, please be as engaged as you can and think of ways that you can push the boundaries and think of ways that you can help Indigenous people that might be different to what we've done in the past, because no one else is going to do it for us. We are responsible for this. And in this country we've got, people with trachoma. That's a ridiculous state for us to be in 2016 in Australia, one of the wealthiest and luckiest countries in the world. So, just thank you, and please, if that's the message that you take away, just don't stop trying, then that would be fantastic. Thank you.
Now, sorry. Oh, yeah.
Thank you very much, Brooke and Brian. That concludes this session. There is only a short break now, 15 minutes, and the coffee and tea is right outside these doors because we need you back for the next session. And what a fantastic national conference this is. Thank you.